Yeah, so I am or was a general practitioner. I went to Aberdeen Medical School to 1990, graduated in 1996, and since then spent my entire time trying to integrate technology with medicine because technology was and kind of still is my first love. So over those years, how to use technology within healthcare has been a bit of an evolution. There was a sort of bump in it with the dot-com boom in 2000, but it's always been a bit slower. But I've always tried to do it. And because I really like the sort of general aspects of medicine, I had kind of two options: emergency medicine or general practice. And emergency medicine is great, don't get me wrong, but it's also punishing on your personal life and work life and everything. So I became a GP, and between 2000 and 2024, I worked as a GP very much full time up until about 2018. And I specialized in urgent and out of hours care as well. And all the way was trying to do technology within it. But within the NHS, either in Scotland where I'm from or in England where I live now, it was always that wee bit slower and harder to do so. And as technology started to accelerate in the mid 2010s, I started doing more within the NHS. But I switched to a company called Babylon. And Babylon is a company that's no longer here, but between 2013 and 2023, I want to say, it grew huge. It was a telehealth company that used a lot of artificial intelligence and ended up providing care in many places around the world, including Rwanda and America, Asia Pacific. And I got brought in 2018 as their director of digital health and innovation, because as a GP, I was combining technology and medicine and safety. But when I came into Babylon, I got access to the kind of commercial and the kind of innovation side at a really incredible rate, and particularly AI. And my job was to try and get the doctors and epidemiologists and clinicians working well with the product team. And when I got there, that was it. I was very, very happy. Was there for 4.5 years. And then when I left, I realized that combination was exactly the kind of doctor that I wanted to be, because I'm a doctor that practices medicine, not through seeing patients, but building products. And so I set up CURISTICA, then the innovation consultancy that I founded that's grown over the last 3 years. And our job is to essentially make AI safe and for people building it and deploying it. And that's how I kind of went from one to the other. There's lots of detail in there, but it started with me loving technology and realizing that it has to be safe for people to use it. Just being a frontline clinician, I mean, well, to start with, I'm a total geek. You can't see it, but I've got like mountains of computer tech and gadgets all sitting around here. So I love that sort of thing, and I do it anyway. And it always was a pain to be working as a clinician and having technology that was at least a decade behind where I was generally using it outside that. And then as a clinician, every person working in healthcare knows there's all sorts of problems in front of you. And the frustration for me was that I potentially had all the solutions, on that side of the screen, but it was very, very hard to get them in front of patients. And so I spent a lot of time thinking about what the good solutions to those problems were, and increasingly over my career started to work out how to do that. But it was very, very difficult to scale it and to bring it across. And so I was able to do great things with technology in my own personal practice or in the practice or sometimes even wider. But I want to be able to assist with that global problem, which is healthcare demand massively exceeding supply. And technology is probably our best way forward on this, because we can't have lots more doctors and nurses, and that hasn't worked so far, and it won't work going forward. And prevention is critically important, but always a challenge. And I see technology as being able to bridge that gap, particularly modern technologies and AI, and getting to that point where people can increasingly care for themselves. I think the thing working in digital health environments, particularly when I went into the commercial side of things, was an unlock in the scope and the vision. When you work within the National Health Service, and it may vary around the world, but I think a lot of people will know this, is that, of course, things have to be safe. Things have to have evidence behind them. But in large organizations, and the NHS is a kind of constellation of large organizations, things move extremely, extremely slowly. And there's a culture of waiting for someone to give you permission to do something, and that can take a long time. Now, there's a lot of good reasons for that, but it means it moves quite slowly. And often the other thing as well, in working in a public health setting, is that this isn't really about being rewarded. It's just like the only thing that can happen if you try and do something new is you expose yourself to the risk of being punished for it. There's no kind of upside to it, if you see what I mean. Working in the commercial setting, that all completely changed. And that kind of audacity of vision with a commitment to try and do it right was the bit. Once I got there, I think this is it. I want things to change, and here are some brilliant people that also want things to change. But I have a certain perspective, and they have a certain perspective, and so I felt really that we're working as a team towards something. That was the big unlock for me. And there were some really, really sort of great strides forward that we made that actually happened when I was working at Babylon. Things like video consultations and the use of AI symptom checkers. People would send me really crummy messages. I'd have people threatening to refer me to the GMC, and what I was doing was criminal and unethical and so on. Of course, where we are now, people just sort of go, oh no, of course we use video consultations or whatever. So kind of goes with the territory. I think the reason that it's frustrating for frontline clinicians is it's a lot of the technology that's used within healthcare. So again, I'm talking about the UK here, but I think it's generalizable around the world, it requires a lot of effort. It's built by large organizations. And there's a lot of kind of monopoly solutions or duopoly solutions. So an electronic health record or patient record, the clinical system that clinicians will use, is a difficult thing to build. And so large organizations build them. And they'll build them to satisfy the needs of a wide population. And they'll move at a certain pace. But of course, the practice of medicine or healthcare gets increasingly kind of tailored and personalized right down to the individual clinician and the patient in front of them. So I think the first frustration is that you get a kind of average solution across things. And that means that it'll do some things well, but for the most part, it won't cover some of the things that you want. And you have a very low chance of getting the solution changed because you're dealing with a big organization. So I think that's the first thing. The second thing is a lot of the solutions are there to solve multiple problems in healthcare. It's not just the delivery of healthcare, but it's the administration and the billing and everything like that. And if they're given equal weight, you'll get a system that's not only average across everything, but that's divided up amongst administration and billing and so on, meaning that the tool that you need to do your job is not fully capable of all the things that you need to do. And it kind of constrains you. And I think people find that very frustrating. And as a result, people don't have enough time to train and use it. They learn workarounds. And, it's a little bit like the tail wagging the dog in some regards. You want to practice your medicine, but the only medicine that you can practice is based on the tools you're given. And I think that's the biggest frustration. The second one, and again, this is maybe more UK specific, but maybe not, is that the computer on the desk in front of a clinician is often much older than the computer in the person's pocket or at home or anything like that. So, you'll be using technology in one place and it'll be, have a certain expectation. And then you step back a decade or 5 years on this slow, clunky piece of technology that's very locked down. I think the combination of those two things, and then you add on top of that the pace of medicine, meaning that you don't have the tools that you need to do your work. And you're limited in your kind of creativity on how to solve it. All those things combined. Well, there's a lot of them, but if I try and boil them down, the most common one is that they don't seriously consider what's needed to implement something correctly. And at its heart, it is the thing that you're implementing actually solving a problem that matters to the person on the front line, right? Quite often, technology will be brought in to satisfy a need that's away from the front line. And so they'll be implementing something that doesn't much help the person. And therefore, you're kind of almost sort of forcing extra work on them. But even when you do get something that's dedicated towards solving a problem that a person has on the front line, often the people making the decisions haven't got as much experience of what the reality of it as well. So the solution isn't a great fit for it. I mean, that's the first one. The second big one is that not nearly enough time is spent training and supporting people to use the technology. Any of the technologies that get put down need a certain level of expertise or understanding to do so. And you can't just drop it in and say, yeah, just get using it, you know, and that's not just an oversimplification. Over my years, that's exactly how it was done. It's like, this is simple. It's much like the other system, just use it. And we'll maybe come on to the clinical safety side, but when training and understanding how to use the tool is such a critical part of making it safe, to just sort of skip through it is not a good idea. So I think those are the sort of two things, and then not supporting people on an ongoing basis. It's not a matter of just doing it once. You know, these are critical tools, and in the same way that we continually keep our eye on the doctors and the nurses for governance and the drugs and the hardware devices, the digital technology needs the same attention. I think it's all those things. Well, they're not too quick. They're too slow to do it. But they also don't fully understand the risk as well. And I'll give you an example, and we'll talk about clinical safety in a little bit, but there's a clinical safety standard that is a legal requirement in England, in the UK. It's best practice in the other home nations in the UK. It's been a requirement since 2012. And last year, me and my colleague Yusuf Ascrocci and Elliot Roy Hiley and Sam Shah from UCL published a study in the JMIR looking at the compliance with that standard in English trusts and in English ICBs who commission services. And we asked simple questions. How many technologies do you use? Of those technologies, are they compliant with the two parts of the standard? And how many clinical safety officers, the required person to do this work, do you have? We got quite a high response rate from within that. But the finding was that there was over 10,000 technologies that were being used, 10,000 instances of technology being used where they had not completed either part of that. That's not to say it's unsafe, but they just hadn't done the compliance work that they needed to do to demonstrate that it could be used safely as well. And so that just speaks to the fact that people aren't considering the risks. And it's not an intuitive thing. It's very similar to governance, but you need some expertise and experience, and people just weren't doing it. And that can have consequences. This is the big bit, because I suppose people, if you ask anyone and say, like, you know, this technology, is it going wrong? Is it harming people? People find it very difficult to immediately call to mind when it happens. And that's because there's a few things. I suppose people aren't really aware of what happens when it goes wrong. It can be subtle, or they can work around it. And they're also often a distance away from the outcome. So they may assume that health technology can't cause harm. But I have a database of where it's gone wrong. And so I'm going to give you a couple of examples, or maybe 3 or 4 examples. So again, these are UK-based. But a big one that maybe people around the world heard about was there was a cyber attack, a ransomware incident at Guy's and St Thomas's in London back in June 2024, where through a lab system, a ransomware attack took place and locked down access. Now, that took out the laboratory services and blood transfusion services for that place for a good few weeks, if not months. And so what was the consequence of that? So I've got some numbers, like over 10,000 outpatient appointments were postponed or cancelled. Nearly 2,000 elective operations were postponed. All primary care testing in the area that was served was delayed and disrupted. And really tragically, at least one death occurred as a result of this. A coroner's inquest has attributed that. That was last year, they talked about that. And in 2 of the areas, 5 cases of moderate harm or 114 cases of low harm from 1 ICB. For 4 London boroughs, 2 cases of severe harm, 11 cases of moderate harm. You know, so one ransomware attack absolutely physically harms patients and delays care and disrupts care. Or another thing is about something as simple as sending letters out to patients. There's something called the HSSIB in the UK, which looks at health and safety, or the safety investigation. And last year they looked at electronic patient record systems, those big systems in there. And they're looking into it more this year about referrals and communications. But, you know, in 2024, they unearthed, not them, but there was some Freedom of Information Act that showed there were 23,000 letters not sent out from one hospital in Newcastle, 400,000 in Nottingham, linked to over 100 serious harm incidents. And this is people getting their results, their appointment bookings, things like that, you know, and no one had noticed it until they noticed it. But the really telling one, and this is a really kind of, this goes back to the millennium bug, all right? You look like a young man, maybe you don't remember the millennium bug, but I remember all the preparations in 2000 about date error, and we did a lot of preparations. But when you screen for Down syndrome, trisomy 21 in pregnancy, there's a test done which calculates whether the mother, the pregnancy has a high or a low risk of leading to this outcome. Because of the millennium bug in one bit of software, it led to errors in that calculation. And over 7,000 women at the time were found to have been affected. The really important bit is that 150 of those women who are actually low risk were told they were high risk. And 2 of those families chose to have a termination of pregnancy. So that was one small area. And I always use that example because I don't think anyone can hear that and not immediately think of the consequences of something small having gone out that has this sort of lifelong consequence. You know, and I've got countless other ones of these as well. So technology can really, really help. Don't get me wrong. I'm not making an argument for not using it, but we have to test it and deploy it and monitor it safely. And if we don't, these sort of things are going to continue to happen. And with AI coming along, we're putting more technology in, you know, it ramps things up. Well, I mean, countless times. I mean, I can always start, well, I like sort of starting with just patients themselves. You know, the advent of the internet and mobile telephony means that people more than ever have more control and understanding over their own health and wellness. And my entire career as a GP was spending time seeing patients, being able to do this. Now, sure, there are some downsides about misinformation and so on and so forth, but overwhelmingly, people are better informed and more in control of their health and increasingly can access services that way. So I think just for a start, when you think about it from a patient and their family's perspectives, I think there's been countless things improving. For me, working as a GP, other technologies that have really helped along the way is just electronic patient records. In primary care, I know I was complaining about them, but actually the ability to have all that information to hand and the lab results and everything just allowed me to just get a much better understanding of what's happening with the patients and making referrals. And then along the way, particularly with digital systems and AI coming along, we've seen symptom checkers, reducing the sort of burden on patients working out whether they need to be seen or not. And most recently, ambient voice technology, which is where you use AI and it scribes, it captures the audio in the room, transcribes it and turns it into text, but then summarizes it, meaning that the clinician and the patient can actually listen to each other and not spend all their time typing. And there's really strong emerging evidence that it really improves that sort of sense of connection and, you know, general well-being on both sides, and can conceivably also save time within there too. So, you know, there's just a couple of examples or 3 examples through there, and there's many, many more coming along. So I think for all the pains that I described, I think it's definitely worth pursuing.
I can imagine that anything that allows for the process to go faster, just because of, I know, like within the NHS, the backlogs, it's such a big problem with you
Yeah.
guys.
Well, yeah, exactly. And I think everyone around the world has their own versions of this, but it's not
Mm.
just about just seeing more people faster. It's also about taking more time when the person's in front of you, because, you know, a person can go and see their doctor or a nurse and get the right outcome, but be rushed through and not feel cared for at all. When we use these technologies, if it frees up some tasks and some time, part of that could be about seeing more people, and we have more people to see. But it really should be spent actually with the person with you and connecting with them and helping them understand,
Mm.
because the quality of the care that you give means not only the patient and their families feel better, but the people providing the care feel better. They don't feel so burnt out.
Mm.
And also, you are more likely to have that treatment work and stick. They're going to come back less often. You're going to be able to cover more. So it's not just about seeing more. In fact, I think seeing more people is possibly not the right way to do it. I think we need to, well, the line I always use, it's not about seeing more patients, it's about seeing more of the patient,
Mm.
more understanding what's happening there. Well, there's a few, and they're kind of changing because the technology is changing an awful lot. But the responsibilities you have, you're deploying technology in healthcare. If I sort of break it into different areas and we can go into each of them, you've got data protection. And in the UK, we have the Data Protection Act and GDPR. It's the same in Europe, and around the world, there are different data protection standards. That's critically important. Healthcare information is extremely sensitive and very valuable to the person for providing care. And they have rights and we have responsibilities about handling that. So handling data protection is critical. And actually people have a general sense of that because there's mandatory training on that too. They maybe don't know as much, but that's often put in place. And so in practices, if you're working in a practice and you're using technology, you'll want to make sure that you have a list of your technologies, you'll have data protection impact assessments and data processing agreements with the people that are doing this. It's often done by the commissioning organization, but actually if you're commissioning something yourself in a practice, you're going to want to address that. And bear in mind, the practice is the data controller here. And that means that you have quite stern responsibilities that if you don't deal with them, can attract very large fines. And practices, if you're in a general practice in the UK and they're a partnership, these are unlimited liability partnerships as well, meaning that that fine could swoop in and not only cost the practice, but cost the partner as well. So I think people are aware of data protection a little bit more, but that's definitely one that you have to be aware of. Clinical safety is the next one, and that's the one that I care about very much because this is about making sure, or clinical risk management, making sure that the technology that you use is safe to use. That starts with saying, what does the technology do? Who does it do it to? And where does it do it? So what does it do? The manufacturer needs to say, this is what we're doing. And you systematically work out what could go wrong and what controls or preventions you put in place and how you've evidenced it. So you can say as a manufacturer, yes, if you use it this way, it's safe to use in care. But in the UK, particularly in England, there's another side for the deploying organization. It's called DCB. The 0129 section is the manufacturer. 0160 section is for the deploying organization. And you basically say, right, I've got this technology that I'm going to use for my patients, maybe like a scribe. Manufacturer says I have to use it this way. Can I use it this way? Is my practice any different? Am I going to be able to train everyone? Am I going to be able to monitor it to make sure that if things go wrong, and things always do go wrong in some way, how do I minimize any harm and learn from it? Clinical safety is the bit that I mentioned earlier on that was legally required in England. And many people don't know about it. There's endless discussions as to why that's the case. But you need someone called a clinical safety officer who's a registered healthcare professional, currently registered, who has training in clinical risk management. And that's the big gap at the moment because practices don't often have these. They don't need one of their own, but they need to know whose theirs is. And that's the person that helps manage this risk management. So that's the clinical safety side. Cybersecurity, we mentioned a little bit earlier on with Guy's and St. Thomas's. That's often done at a commissioning body level, but practices need to know about making sure that people have the right passwords and smart cards and aren't installing applications that they shouldn't just in case it causes problems. Medical device regulation is the bit that people sort of think about a lot, which is this software doing something that would make it considered as a regulated medical device? And all around the world, there are different rules. The UK is close to what Europe has as well here. But basically, if this is software or anything that performs a sort of diagnostic, therapeutic, prevention, or prediction, a management task might be considered a medical device. And there's a lot of certification that happens with that. Practices want to know that. And then there's a few other things on top of that. I won't go into them in all the detail, but it's about how they integrate with other systems, whether they're usable for all people, not just a small group, young and old, different demographies and so on. Those are all in there. So it does feel very overwhelming for practices and people that don't know it. But it can kind of be boiled down, and it's actually quite similar to what practices do right now for managing their staff and their prescribing and so on. So a lot of the work that we do with the people that we help is about trying to wrap it in and get people to feel that it's not just like another huge headache. It can be part of what they do.
Awesome. Um,
Yeah, well, thinking about that, the safe and effective one is all about considering it from the start. Um, I think people sometimes look at compliance or governance or safety as like just a sort of painful thing that you kind of you do your thing, it gets in the way and everything like that. And actually, maybe traditionally they've been kind of right because of how it's been approached. But when you're trying to solve a problem, whatever it is, so let's say it's the problem of doctors having to spend a lot of time typing, yeah, like so a scribe or something like that. You have a series of requirements, that has to solve that problem. It has to do so in a way that's usable and so on. That it has to be safe is also a requirement. And so the thing that separates risky from more thoughtful innovation is considering these things right at the start. Now, that doesn't mean that you then have to like crawl along at all. Not at all. It's just about knowing it and saying, well, this is what we plan to do. These bits here are areas where it might be more risky or things. So we're going to take more care here. We're going to test that a little bit more, and we're going to plan our route through that a little bit more easily. With AI now allowing many more people to build much more easily, it's easier than ever for a person to think, oh, I've got an idea. I'll go into one of these vibe coding platforms. Bang, it's done. And it looks like it's working, and so I'm going to go and use it. But what they maybe haven't done is they've considered, well, how could this go wrong? So if you wrap that in at the start, that's the main difference between reckless and thoughtful innovation. The thing about if you don't do that, you're going to have to do it at some point anyway. And we call that compliance debt. You can either accrue that through not knowing anything or not dealing with it. You can do it thoughtfully. You can plan this, which is better. But, you can go along and either something bad will happen and you'll pay the price anyway, or you'll suddenly say, oh, I want to sell this on the market. And and then the person you sell it to says, yeah, show us all your documentation. And you think, oh, crikey, I hadn't thought of that. And I tell you something, at that point, it becomes very painful and costly. Well, it's also another slightly tricky thing because AI, like no other technology, is moving exceptionally fast. I think AI has some really remarkable properties, but a lot of them it shares with any digital health technology. So to adopt AI, you want to think about adopting technology more widely. For an organization to do that at the highest level, think about what you do for governance of everything that you do and consider how you would do that for technology as well, like AI and so on. Now, there are some details within that. Of course there are, but you start with that, has all the due diligence work been done on this? Can I use this thing here? Like, am I allowed to use this thing here? And in doing that, am I allowed to use it? That's checking the compliances. The other thing is understanding the people that are going to be using it, not only your workforce, but the patients on the other side as well. Like, if you want to have more confidence about AI, you need to know more about AI. And people will often say, what course do I do? What book do I read or anything? That's all great. But AI, unlike any other technology, really benefits from just using it. Um, and so the recommendation I have for everyone is as they work that through for their own practices, like, well, do you use AI, like ChatGPT or Claude or something like that? If you don't, start using it, but don't use it in healthcare just yet. What hobbies do you have? What things do you do outside that you enjoy, that you know a decent bit about amount and you'd find some benefit from? And start using it there, because that way you really learn about what it can and can't do. AI can do some things incredibly well, some things it's really useless, but it varies from person to person. So I think the other thing is actually starting up on personal use too. And then the other bit is within whatever organization you are, try and identify people that know about this, either your champions or experts within the organization that you have, or you can come to us. We can help as well at Curistica. And yeah, start on the process of raising awareness of this too. I think as society, we need to start teaching more about these technologies from school, let alone university everything because these technologies are here to stay. Um, but I can't solve for that. I do try. I do go a lot of talks at medical schools and the like, but it's going to take a wee bit of time for that.
And the way that you're saying it actually sounds like it needs to start even before that, like even
Oh
before
yeah,
going, like, yeah, like primary
I'm
school.
exactly. And if we don't do it, people will learn anyway, but they'll learn in a kind of experience of the world way, and that'll be more consumer technologies.
Mm.
People need to use it, but there are some basics that they need to know. Um, and yeah, it's going to take some time for all of that to kind of come through, and it's harder because the technology is moving really fast. But
Yeah.
we do need to sort of move forward in a lot of different areas. So in a practice, it's about like if you're in a practice, if you're a practice manager, the first thing you're gonna want to do is like, well, what technologies are we using? And it's actually surprised, like practices will sometimes struggle to say exactly how many. They'll have between 10 and 20 different technologies, some of which have been provided for them, some of which they've got themselves.
Mm.
And so understanding what your technologies are, and then have we done everything we need to do for each of those is like your first step. Now, I'll warn everyone, when you do that for the first time, there'll be a lot of red on that graph, but everyone's in the same position. But that allows you to then address that. And this is something we maybe talk about it in a moment. We have a free tool that people can use called Assess, which is at assess.curistica.com. And I'll share the link, which is free to use. We don't retain the information. People can use it to get a report to help start understanding what technology they have within a 5 or 10 minute walkthrough. Yeah. So the clinical safety officer, as I mentioned a wee bit earlier on, currently registered healthcare professional, doctor, nurse, physio, pharmacist, something like that, who has experience in clinical risk management. That structured approach to understanding the technology and how it's going to be used and how could it go wrong, how are we stopping it going wrong, how are we monitoring it. That's what they do. They will work sometimes employed in an organization. So bigger organizations like hospital trusts and some larger practices and commissioning bodies will have them. And what they will do is they're essentially responsible for getting this work undertaken. They're not always writing all the documents or everything, but they're coordinating the activities. And the activities get broke. The responsibility of an organization is to resource for that, as in to fund and get access to these people. And then that clinical safety officer will work with them to say, well, how is technology and AI governed in your organization? That's your governance, called a clinical risk management system. And then for each technology, well, we're going to deploy this one. Do we have to do anything special with this one? That's the clinical risk management plan. And then there's two other things that get produced, something called a hazard log, which is currently a spreadsheet, but it can be done another way, which is a sort of step by step, like at this point, what can go wrong? At this point, what can go wrong? And how likely is it? What would happen if it went wrong? And how can we stop it going wrong? That's the hazard log. That's your kind of thoughtful assessment and evaluation of risks. And then at the end of it all, once you've got all that information together, you do something called a clinical safety case report, which is essentially your argument saying, we're using this technology to do this. This is who we are. We'll use it this way. So we'll have to do some slightly different things. Here's the proof that we did it. We're safe to use it. And we've also got a plan in place to deal with things when the product changes or there's any issues. Clinical safety officer helps coordinate and put that in place and make sure it's all up to date. At a practice, might not need to have one there, but practices can group together. So in the UK or in England, you've got primary care networks or federations. You can kind of share the role. And what we do at Curistica is we'll often either be that person or help support people, because we have a lot of expertise here to help support them work through things. Or even at a higher level or in hospitals and ambulance trusts and everything. So that's what the CSO is. And it's
Yeah.
something that really benefits from experience and technological knowledge. Yeah. So earlier on, we spoke a little bit about those different pillars. And so we've
Hmm.
gone through them a little bit there. I think the way that they fit together is actually how you've asked the question is the really important bit. They do fit together. And traditionally, they've been done very separately. So you'll have one person doing data protection, and one person doing clinical safety, and one person doing cybersecurity. And they'll all be in different places, and they won't talk to each other. And what that does is that leads to some unnecessary duplication and also the risk of gaps emerging. So, for example, data protection, the personal and special category data, which is very, very sensitive, if it goes to the wrong place, if it's corrupted, that can cause patient harm. It causes organizational harm and financial risk, but it can harm someone. Simply put, if your medical records were accidentally sent to the wrong place, you would be upset about that. Yeah? At its simplest, right? And that is harm. And I know it sounds trite to sort of say it, but if you speak to anyone to whom this has happened to, psychological harm is no laughing matter, and it can have really bad consequences. So you want to consider data protection in cyber and clinical safety, but equally the clinical safety controls you put into place need to work with data protection and cyber security. So they all do dovetail, and having one person who knows absolutely everything is very hard. We know a lot about those things too. This is why what you want to try and do is have a kind of coordinated effort and trying to integrate it. And that's going to take some time to work out exactly how best to do it. I think we're all still learning a bit there. But the early signs from what we do is that when you do that, people just feel generally a bit more comfortable and things are less likely to go wrong. And ultimately, patients are safer. So right now, I suppose most practices, they start thinking about it because they want to implement an ambient scribe, is generally what happens. So they say, oh, we want to use a scribe to do the transcription. And we know it's AI. And there was a letter that came out from the CCIO in NHS England in the middle of last year, which said, and you must do this work. So they're very, very clear on that. And so we get approached by this, so they're asking about it. And the first thing that happens is you say, yes, we can do all the work for that, all these standards. But do bear in mind that digital health technologies, this is the important bit, any digital health technology or AI that can affect patients in a real-time or near real-time way needs to have this work done. And that's not just healthcare, but it's adult social care too. So when they understand that, most people start to go, say, well, we use a few technologies. At that point, you say, all right, yes, well, you're going to have to address those. And then that's when their heart starts to sink a bit because they go, I don't think it's all been done. That's why I talked about assess, which is if you ask someone how many technologies they have, because not all of them have been commissioned by themselves, some of them are just sort of put in, they'll say, well, doesn't someone else deal with that? And then they're like, but we do have these technologies. Does it count for those? So that's why we built Assess, because it allows you and guides people through. They just tick off the things that they have, and they'll often see things that they hadn't even thought about. And at the end of it all, like I said, they'll have between maybe 10 and 20 of them. But they'll also know, well, do we know the data protection, clinical safety, and cybersecurity and device status of these? Don't worry, folks. Most of you won't or won't be clear. But that's the whole point. You start with that and you go, okay, so this is the whole of it. It's going to take some time to work through, but now we know where to go to get started, because some of it will already have been done. So if you're in a practice, the ICB may already have done the clinical safety, data protection, cybersecurity side of things. It's just a matter of assuring yourself of that. But there will be some gaps, and CURISTICA helps fill those gaps for those people that need the help, or if they need some help for their own people to fill it in. It's all about turning this kind of confusing and technical piece, learning about it, and then saying, right, here we go. And importantly, in England in particular, with the Care Quality Commission, they have a position on this. They're starting to look into it more. So practices are like, oh, what happens if the CQC comes past? So everything that we do is about providing the evidence to help someone like the CQC feel comfortable. But as the CQC works out exactly how they're going to do it, we have conversations with them and say, as you're working this out, we understand the principles of what you want to do. And they put out some things. This is how we're helping practices and PCNs do it. If they gave you a list saying, these are the things, this is what we're doing, would you be happy? And the CQC in conversations appear to be happy with that. So I think it's going to take a bit of time to get a formal position on that. But you don't have to have everything perfect for when they arrive. But what you do want to say is, we know what's going on and we have a plan. Well, the CQC are there to sort of assess the quality and service you provide. And if you think about it, I sometimes say to people, as a doctor, you can spend some days not prescribing anything at all, right? But I'd be hard pressed to find a doctor that didn't use technology in the day. The very few of them would have that in some form. So it's a core part of how care is delivered. So it makes sense that the CQC, if they're assessing the quality of the service you're providing, would want to know that you're using that technology right. Yeah. So it's the basic principles about that, and that you're engaging with your patients, that you're making sure that everyone gets equal access to service, because some patients are less able to use the technologies, sometimes by virtue of their age, although it's not quite as stark. Older users are often better. But some socio-demographic groups would find it difficult, particularly if the technology only works in English, let's say. And you have to say, well, we're using this technology, it works very well. But for those people that find it difficult, we're either assisting them or providing them with alternative routes. So the CQC will use their current approach with technology. What's not clear just now is exactly how they're doing that. So while the CQC works through that, we at Curistica and some other people are waiting around, and we're trying to help solve for that problem. And then in an open way, share it back with the CQC and say, we think using first principles and our knowledge of technology, this would be a good way to demonstrate this. And I think that way we can assist. So I talked earlier on about the study that we did that was published in the JMIR, and I can share the links for the show notes for that. That looked at ICBs who commission the services, including primary care and care homes and hospitals. But the mechanism by which we were able to get that information, Freedom of Information Act information, won't work in the same way. And there's many more practices and care homes. So we don't know. You don't know. However, I suspect that the situation is probably even less strong than it was in the trusts, in part because it hasn't really been on their radar in the same way. And there's so many things on their radar at the moment. I'm not surprised. I'd say care homes are probably going to be the really unknown area. But in the practices we work with, they often are only just really getting started in this area just now. So I think anyone listening to this or watching this may think, oh, crikey, I think we might not be any good at this. Everyone's in the same boat. And I always say when I speak to people about this that, it's great to aim for perfection. Any steps you take to make things safer is moving you in a better place immediately. And some of those can be really simple. So one I would say for any practice or organization listening to this is that just make sure that your staff know how to report an issue if something goes wrong with the technology, because that's the big gap. People never report stuff. So if you speak to them and say, look, if you're using it and it's not working, if it's slow, if you've managed to catch it and fix it, whatever it is, still let us know. Because at that point, you start to get a sense of what's happening and can start doing it. And if you do that, just that one thing, and then the second thing is make sure that they've read the manual, know how to use it, you're instantly improving the safety of what's going on at minimal cost.
That actually makes a lot of sense, because as you're saying, like one of the biggest issues is the fact that we are introducing all this technology, but then the training doesn't go along with it. So the machine's working, or the AI technology is working in a certain way, so you're expecting it to work away, but because you don't have the training, you're not sure if it's working correctly. So you don't
Well,
know if
that's
you're
it.
supposed
Yeah.
to.
Yeah.
So you don't know if you're supposed to report it or not, because is it supposed to be working like this or not,
Yeah. Well, that's exactly right. It's like if you don't know what it's meant to work like, and then you're
Mm,
using it and it's not working, you might just expect that that's what it is. Maybe you've probably landed on probably the biggest reason is that people just expect it to work the way it is, which is not well. Like
mm,
the GP systems in the UK, there's one in particular that is famous for just being very slow. And so I sort of speak to people in talks and say, how many of you use technology every day? And their hands go up. And I say, how many of you have reported an incident or an issue with this? And very few hands go up. And then I say, all right, to all of you, how many times did your GP system go slow or crash or anything? And like all the hands go up. And I say, okay, so you're saying that you use technology all the time, it's always going wrong, but you've never reported it. And
mm,
but there's lots of reasons for that. They don't know how, they don't, exactly as you just said, they don't know that it's gone wrong, or they feel that reporting it will make no difference. And actually, maybe that was the case. But unless we fix that, when, and then we start adding more complex technology on top. Yeah. So again, they haven't been very, very explicit about this just yet. So my opinion, and actually those of some of the people that work in the space as well. So when the CQC come in, and in fact, there's a link I'll also share with you. The CQC did a Mythbusters on artificial intelligence. They talk a little bit more in there. They're going to want to see not you just talking about it, but some proof. So what kind of proof would that be? They'll want some proof that you have done the due diligence on the solutions that you have, hence us making assess and a sort of list of your technologies and have you got everything and where is it? And again, that might be blanks, but you're working on it. So they'll want that. When you do the clinical safety work, you're also sort of saying, well, I'm going to train everyone and we're going to monitor it. And if there's anything goes wrong, we're going to look into them. So they're going to want to see some evidence of that. And the easiest way to do that is if you have in your monthly governance meeting a line item, which is like just technology, and you just say, what technologies are we using? Is the training up to date? Were there any incidents? And are there any new technology changes coming along? If you have those in your governance meeting, and they're in the minutes. So when the CQC come past and say, are you doing all this stuff? You go, yeah, here's the minutes, right? You want to make sure that you've got the documents that it points to and you've done it. And then the other thing that I strongly suspect they'll do is they'll say, has anything gone wrong? Like a complaint or an incident. And if you say no, that seems unlikely. So they maybe push on that. So if you have one, that you maybe have one or two that you can show that you've worked through them. I think those are maybe the three areas, plus showing that you've discussed it and shared it with your patients. The patient's perspective has been considered within there. So your patient participation groups have been involved with that too. I think being able to demonstrate that you know who your CSO is, and like I said, they don't have to be employed in the practice, but you could know that. I think all of those things would be pretty strong evidence that you're doing it. And if you're maintaining it as you go along, shouldn't turn into a mad scramble before the CQC arrives. Yeah, we support all sorts of people. So I won't talk about the manufacturers so much, although we do a lot of work with people building advanced technologies. And the reason for that is that we want them to make it safe and allow them to move quickly but correctly. So we work with them. For healthcare organizations, we'll work with individual practices who say, I just want to put a scribe in place and I hear I have to do this. So we do a lot of that. More commonly, what we do is we work with primary care networks or collections of practices because it can be a wee bit more costly for one practice to do it. But if you work across a few practices that work in a similar way, you can contribute a smaller amount and actually have it all done across that way. So I think primary care networks and above that, federations and neighborhoods would be there. ICBs in the UK, or at least in England, are going through a lot of change right now. And so we have had conversations with them and some, we speak with some of those. And of course, we work with hospital trusts and we just worked with a mental health trust on ambient voice technology. Out of our sector, in short, if you want to use technology to provide care, we will. But my background as a GP means I just know how busy it is. And I'll be damned if I'm going to make something harder for you. We can be your clinical safety officer. We can support your clinical safety officer, or we can support clinical safety officers and data protection officers as well. So either we can do it for you, or we can help you do it, or we can just be on the end of the line for the awkward questions. So that's the basis of this too. And in practical terms, you might be saying, I want to put in a scribe. I want to make sure it's done right. We don't have anyone in-house to do this right now. Can someone help us do it? We can do it for you. And my aim always is not to give the people fish, but to teach them how to fish. Like it's great to be working with them, but clinical safety and compliance in general is something that everyone has a role to play. So getting people up and running and then supporting them is the best way. And we have our own technology that we use to help us, and we're working towards making it available to practices to make it easier for them too. Well, surprised. Earlier on, it's called Assess, and anyone can access it on Assess. That's ASSESS.curistica.com. And essentially, it is a web page. It takes about 5 minutes, maybe 5-10 minutes to work through, We don't retain any information in it. There's no cookies or anything. And you go through and you tells you a little bit about all these terms. And then you can identify the technologies you have, where you can either list them or it'll guide you through it. And then for each of those technologies, ask the basic questions. Do you have the safety case? Do you have the data protection information and so on? If you don't know, you can say, I don't know. Then the last part of it is just like, how do you run governance? Do you have a clinical safety officer? How do you do governance in the organization? I promise you it's quite quick. At the end of it all, at that point, you get a short report. And if you want, you can provide your email and you'll get a fuller report for it, all for you at no cost. And the only bit that we've got our privacy policy and terms and conditions within there. If people want us to get in contact, of course, they can indicate to do so. The bit of information that we like to look at is what technologies are being used, because that's a gap, is like who's using what. It means that we can help inform people which technologies need the most care. I was going to say, don't be afraid of it. I think it is actually right to be slightly afraid of it because it's a very advanced technology. So, you know, I'm not going to be all hearts and flowers. It's going to be tricky to put it in place. But what I will say is don't wait. Don't wait for it to be solved before you get on board. It is moving so fast and there's so much benefit that can come with it. But equally, there are some risks. And if you don't address it, people are going to use it anyway. We talk about shadow AI a lot. You know, there's surveys looking at, you know, GPs may not have ChatGPT to use in their practice, but they're using it. And it's that risk that's probably the biggest of all, is that if you don't help provide the tools, people are just going to use it, but they're going to use it in a way that's maybe much more risky. So I'd say do not wait around. Start to take a position on it. Start to engage your staff and patients about this. Share information and find the small things you can do and find a way that people can use AI in a safe way. Because like I said earlier on with hobbies, using AI, everyone has different strengths and weaknesses, and AI has different strengths and weaknesses. By using it, you work out when AI can help and when you should be doing it yourself. It's very personal. Do it that way. And you can start practically in your practice or anywhere. You will guaranteed have some slightly geeky person in there. I was that geeky person. They will probably jump at the chance to pick up on this too. And if you don't have one within your network, you'll find some other people too. So my advice is be appropriately wary, but don't wait around. Find a way to start using it. Yeah. So I love talking about this stuff, as you probably guessed. A number of ways. If you go to our website, which is curistica.com, curistica.com, and I'm sure there'll be a banner on this. Our website has means of getting in touch with us, or hello@curistica.com. I'm on LinkedIn, Dr. Keith Grimes, post a lot there. People can message me there. And there's other routes in, and the rest of my team, Yusuf Oscroci, Erica Warp, and the rest of the team are all very good at responding too. So you can just get in touch. If people are interested, there's a WhatsApp group called AI in the NHS, which is very active. And it has a lot of people who just watch what's going on. I mean, when I say active, it's like several hundred messages a week. But the pulse of what's happening with technology is discussed a lot in practical terms, and we summarize it in a newsletter too. So if people are interested in that, they can also contact me. So lots of way in. I'll share the bits and pieces there. I try and do a lot of talks and the like too. But yeah, very happy to hear about it, because I just care about the technology solving the problems, but it has to be safe. So that's where I focus my efforts.